diaphragm.
Well, welcome to another lecture. We're going to talk about the treatment for shock. Please refer to the lecture called Shock Explained Clearly for the background on that information. But what I'd like to get into is the treatment for the different types of shock. Okay, the three different types of shock we're going to talk about is number one, hypovolemic. Number two is cardiogenic. And number three is septic. And you will remember that we talked about the different pathophysiology of these shock syndromes. Hypovolemic starts off with a low amount of volume in the body from either bleeding or dehydration or blood loss, and that can cause a low JVP, which will cause a low cardiac output and a high systemic vascular resistance. And then what will happen is that the target organs will eventually lose oxygen and they will start to fail. Cardiogenic shock is where the heart initially starts to fail. That causes a decrease in blood pressure, decrease in cardiac output, not enough blood getting to the target tissues, lack of oxygen, and shock again. Septic shock, on the other hand, is where there is increased flow from the heart, increased cardiac output. However, there is a drop in the systemic vascular resistance. There is deregulation of the blood going between vital and non-vital organs, and because of that, the vital organs lose out, and they start to go into septic shock. And I think the picture that we drew for that resembled this type of a picture where we had the bucket, if you will, filled up with the fluid, and then we had the pipes that were leading from there to go to the heart, and then it went off and branched into two different organ types. There was the vital organs, okay, put a V for vital, and there were the non-vital organs like skin, okay, so non-vital organs. And all of this sort of came back together again to complete the cycle. And we said that there are different areas where we could have problems. And I think we labeled those A here, hypovolemic. If your volume is low, that's going to cause problems. The second one was B, or the heart. That was cardiogenic shock here. And if the heart pump is not working very well, that's going to cause you some big problems there as well. And then finally, the septic. Now that seemed to be a problem here in the vasculature, and indeed just about everywhere. You're going to get vasodilation more than others, and so blood may go to the non-vital and not so much to the vital. Okay, so let's talk about the treatment solutions. First of all, let's talk about hypovolemic shock first. All right, so in hypovolemic shock, there is a loss in volume. And so what's going to happen in that situation is there's going to be a stimulus to replace that volume. And the two biggest factors that you're going to see there is the RAS system, or the renin-angiotensin system, with aldosterone. Okay, and the next one is ADH. Now, if you will recall, the renin-angiotensin system is a system or situation where aldosterone is secreted from the zona glomerulosa of the adrenal cortex. Please see our lecture on adrenal cortex for further information on that. And that hormone, which is a steroid hormone, is secreted from the zona glomerulosa of the adrenal cortex and works in the, if you'll recall, the distal convoluted tubule of the nephron to reabsorb sodium and therefore water. And that's going to increase volume. So that's going to work. Now the second thing that happens is the antidiuretic hormone, which is secreted. Now if you recall, antidiuretic hormone is produced in the hypothalamus and is secreted in the posterior pituitary. And that hormone is a protein hormone, so it works very rapidly, and that works on the collecting tubule of the nephron, and that helps reabsorb water. Now, ADH is the other name for ADH is vasopressin. And we can actually give vasopressin to patients as a vasopressor. So this is a very potent volume expander, and so is the renin-angiotensin system as well. So that's what the body is doing, and obviously the body is doing this very early. But if it turns out that this is still not able to compensate for the tremendous amount of volume that's being lost, you're going to decompensate and you're going to go into multi-organ dysfunction from hypovolemia. So if this patient makes it to the emergency room and the intensive care unit, what we're going to give is basically normal saline. And you're going to give it quick and you're going to give it fast because you have it available, it's easy to give, and you don't have to worry about transfusion reactions. Obviously, however, if the patient is bleeding, you're going to do a transfusion. And you're going to have to give that pretty rapidly. You have to type and cross these patients, make sure there's no antibodies. And so the bottom line here is the treatment for hypovolemia is volume, and that makes sense. Okay, so let's talk about the second form of shock, and which is cardiogenic shock. Now, as you know, cardiogenic shock is a problem specifically with the heart. There is medications which we can do to make the heart beat stronger. One of those is digoxin. This works especially well when the heart ejection fraction is less than 40%. So think about that. You have to dose it, you have to load them, and you also have to monitor them. In the acute setting, however, as you know, there are beta receptors on the heart. Beta receptors cause the heart to beat stronger and faster. And so if you really want to stimulate the heart to do that, you should give a medication intravenously which has pure beta stimulation. And the name of that medication is dobutamine. Now, there are other drugs that also have beta. Dopamine is one of them, but it also has dopamine receptors and alpha receptors, and dopamine can make the heart beat faster as well, and it can cause tachyarrhythmias. Dobutamine can also do that, but remember, dobutamine is pure beta. Now, something you got to know about that, though, is beta receptors are also on the vasculature, and that causes vasodilation. So beta, or dobutamine, could actually make your blood pressure go down if the offset in increased cardiac output is not enough to take in consideration. So to review there, beta receptors both in the heart, beta receptors in the heart cause the heart to beat stronger and faster, and there are beta receptors in the peripheral vasculature, and beta receptors there cause vasodilation, which can cause hypotension. So if someone is in cardiogenic shock, you first of all want to find out why they're in cardiogenic shock, and if it's there because of a low ejection fraction, you may want to consider dobutamine. Remember, these patients have high central venous pressures, are cool to the touch, etc., etc. The treatment there is not necessarily volume, but what we call inotropes and chronotropes. That's what dobutamine is. All right, let's talk about the last one, which is septic shock. And for that, I'm going to go ahead and clear the screen. Now, I'm going to redraw what I was showing you before, but I'm going to do it in a little different color, and I'll show you why in a little bit here. So here's our container filled with our fluid. Here's our venous system, which is leading into our heart. Here is our blood vessels leading out, and they're going to our different types of organs, and all of this is coming back and going back to our venous system. Now, I'm drawing this specifically because of septic shock. Now let me show you the problems that happen in septic shock first of all. Okay, so in septic shock, remember that the problem initially is that you get vasodilation and maldistribution of arteriolar output. And this is because you get vasodilation from chemokines, cytokines, and endotoxins from bacteria. So there's bacteria, infections, and that causes vasodilation. Now when that occurs, the blood pressure goes down. When blood pressure goes down, the heart rate goes up, your cardiac output goes up. When that happens, your JVP goes down. So JVP goes down. Also, in your systemic vascular resistance goes down. Your ejection fraction also goes down. Blood pressure goes down, skin temperature goes up because there's just a maldistribution of vasculature. So when this occurs, remember, there are red blood cells. I'll draw little dots here that are bound with oxygen. And what happens here is because there is a maldistribution of blood that's actually reaching the target tissues, there is less oxygen that is reaching the target tissues. As a result of that, and let's just say that our oxygen saturation in our arterial system is 95%, and it goes through the tissues and it comes out normally at 70%. Usually 70% is the saturation in the venous blood as it's going back to the heart. So 70% saturation is normal. What's going to happen is because there's less blood reaching the target tissue, the tissue is going to extract more oxygen than it would normally do because it still needs that oxygen. And as a result of that, this saturation, which is known as the SVO2, is going to go down less than 70%. That's one of the key findings in septic shock, is that your venous saturation is less than 70%. And why is it less than 70%? It's because your target tissues are extracting more oxygen than they would normally need to do because less is reaching it in the first place. And why is less reaching it in the first place? It's because there is maldistribution of cardiac output to these places. And therefore the heart tries to compensate by increasing its cardiac output, by increasing its heart rate, and as a result of that, your jugulus venous pressure drops. By the way, jugulus venous pressure also drops because not only is the arteriolar system dilating, but also the venous system is also dilating. So this is a problem. All right, so how do we treat this kind of a situation? Well, there was something called early goal-directed therapy. This was a paper in the New England Journal of Medicine that came out a number of years ago by Rivers et al. You could look it up. And basically what they said was these patients who are in septic shock typically have elevated lactic acid levels. And lactic acid, as you recall, is simply a byproduct of anaerobic respiration. So basically this lactic acid is being made because there's not enough oxygen getting to the target tissue. So if you see a patient with an elevated heart rate, a temperature, an elevated white count, which is indicative of an infection, and they have an elevated lactic acid level with a low blood pressure, think of septic shock. Okay, so if that's the case, what do we need to do? We need to work real quickly. We need to get stuff done within 6 hours is sort of the standard. And within the first hour, here's number one, within the first hour, you need to get on antibiotics. Appropriate antibiotics with broad spectrum to take care of whatever it is the infection is. If it's a community-acquired infection, then you use appropriate antibiotics for the community. If it's a hospital-acquired infection, then you need to cover for things like MRSA. That's a resistant type of Staphylococcus aureus. It is only sensitive to Vanco in most cases. And also Pseudomonas, which is only susceptible to certain types of antibiotics. We'll talk about that in a different lecture. So within 1 hour, in less than 1 hour, you need to start antibiotics. That's why this is so key to pick this up in the emergency room and get antibiotics on board immediately. What's the second thing we need to do? Now notice it's called early goal-directed. So we need to have a goal, and we need to direct it toward that goal, and then we got to do it. So what is it that we need to do? Number two, what would be the first thing we need to do here? Well, the first thing I see here is that we've got a low JVP. So what we do is we put something called the central line in. The central line is simply a catheter that we put into someone's large vein, either in the neck, the shoulder, or the groin. It works best if it's in the neck or the shoulder. And this central line basically measures what the JVP is. Now, normal JVP is about 2 to 5 in that range. However, in early goal-directed therapy, we really want to boost this level up so the heart has enough blood to pump and we can meet the oxygen demands of the peripheral tissue. So our goal is we want a central venous pressure of 8 to 12, and we want to do that with normal saline. Now, why do we use normal saline? Look at my hyponatremia lecture, and I'll show you why normal saline is the best fluid to use if you want to replace volume. So you keep giving normal saline until the central venous pressure is between 8 and 12. Now, if that doesn't correct your blood pressure, then the third step at that point is to add vasopressors. Now, vasopressors are intravenous medications that go through the central line, by the way. Okay, so they go through the central line, and these are usually alpha and beta agonists that cause vasoconstriction of the blood vessels. So the things that we would use here are something called norepinephrine or dopamine. So these are both alpha and beta. The other name for norepinephrine, by the way, is Levophed. And what is the target? What is our goal-directed therapy there? We want to get a MAP that's a mean arterial pressure of greater than 65. Once we do that, then we're hoping we're getting enough perfusion to the peripheral tissues. So let's say we do this. We start the antibiotics, we get the central venous pressure up to 8 to 12, and we use vasopressors if we need to. The key is, are we getting enough perfusion to the peripheral tissues? And there's a way of measuring that. As I mentioned, the way of measuring that is to check the SVO2. If the SVO2 is greater than 70 after doing all of these things, then we're done. That means that we've corrected everything that we know that we need to correct, and we have finally made the SVO2 at 70%, which means that we're getting enough oxygen to the peripheral tissues because it doesn't need to extract anymore. However, if we do all of this and the SVO2 is still less than 70%, we can measure that on the central line because it's got a little probe in there that's measuring this, then there's two other possibilities that could be happening. And the two other possibilities are the two other factors that are very important in delivery of oxygen to the peripheral tissues. And they are, number one, cardiac output, and number two, hemoglobin concentration. Cardiac output, the higher the cardiac output, the more red blood cells are being pumped to the peripheral tissues and the more oxygen you'll be delivered. Hemoglobin, obviously, the more hemoglobin molecules there are, the more oxygen will be delivered to the peripheral tissue. So we check the hemoglobin. If we've done all three of these things and our SVO2 is still less than 70%. If the hemoglobin is less than 10, we transfuse blood. If it's greater than 10, then we know that there's only one thing left that is not corrected for, and that is the cardiac output. In this situation, we will give medications to increase the cardiac output. Anybody have an idea about what medication that would be? We just discussed it. We would add dobutamine. Now notice this dobutamine is not the same as dopamine. Dopamine is alpha and beta, whereas dobutamine is just beta. It's just hitting the heart. And what we're saying there is, if we're having to add dobutamine, it means that antibiotics, fluids, vasopressors, and hemoglobin were not enough to get enough oxygen to the target tissues that now we need to actually give dobutamine to make the heart pump stronger. That's called early goal-directed therapy. That should all happen within 6 hours of identifying septic shock. All right, so that's basically early goal-directed therapy. I've gone over the different therapies for shock. Now you should be able to identify shock and treat shock. Thanks very much.